Welcome back to Health Law Pulse, the podcast where we explore the intersection of healthcare, leadership, and law. I'm your host, Jonathan Rhodes, healthcare attorney and founder of Health Law Counsel, LLC. Healthcare is evolving rapidly, and some of the most interesting changes aren't coming from large health systems or traditional healthcare organizations. They're coming from clinicians who are stepping into leadership roles, launching businesses, building innovative care models, and helping shape the future of healthcare delivery. My guest today is Amanda Guarniere, nurse practitioner, healthcare executive, entrepreneur, and vice president of Enterprise Partnerships at GuardianMD. Amanda has built a career at the intersection of clinical care, business growth, and healthcare leadership. She has launched her own practice, advised healthcare startups, worked with private equity-backed organizations, and helped clinicians navigate the transition from provider to business owner. In this episode, we discuss why clinicians belong in leadership roles, the rise of provider-led healthcare businesses, the opportunities and challenges facing nurse practitioners, and how healthcare organizations can balance growth, compliance, and patient care. We also explore what it takes to build sustainable healthcare businesses without losing sight of the people they ultimately serve. This is Health Law Pulse. Amanda, thank you for joining me today. We really appreciate you taking out some time to join us on this episode of Health Law Pulse.
My pleasure, Jonathan. Thanks for having me.
Well, Amanda, I want to, before we kind of get into our discussion, if you could just give the listeners a little bit about your background, some of your things you've done in your career, and help provide good context for some of the topics we'll be discussing today.
Sure. So I am a nurse practitioner by training. This is now my 15th year as an NP, which feels wild to say. Feels like just yesterday I was a brand new NP, and I've had an interesting kind of windy career trajectory. I'd say the first 10 years or so of my career were pretty traditional in the sense that I worked a variety of clinical jobs, mostly in the field of emergency medicine. That's where I spent the majority of my clinical years before pivoting to more of a primary care and now more of a wellness and aesthetics environment. And then over the past 5 years maybe 5 to 7 years has really been my foray into the business side of healthcare through a few different avenues. I started off with my own consulting educational company, which then led to an opportunity working in the medical oversight and compliance space, specifically working with companies that help NPs and nurses find collaborating positions. So that's been my full-time area of focus for the past 3, 4 years or so. I am still practicing clinically. I have my own part-time practice on the side. I work one evening session per week and every other Saturday in my own small one-room studio. So still wearing my clinical hat sometimes, but it's been a windy, fun road, and excited to chat more.
Yeah, perfect. Well, thanks for sharing that. And I've had guests on that are were they physicians or nurse practitioners that don't practice anymore. So they've gone into leadership before and they work for large scale health systems, things like that. I think this will be interesting because you actually have your foot in both worlds right now. And so sort of that's the tension or the pull between the business and the clinical side. I think I look forward to your insight on some of those things. But I mean, let's just start there. Right, you have gone and you did mention you're currently practicing um, on the clinical side as well as your leadership roles. But you were formerly 100% dedicated to as a bedside clinician. You've, as you noted, have had this, and so have I. And I think many people have had this kind of winding career in terms of different turns and curves that are thrown at us through life, and just different opportunities that come up. But what skills from clinical practice do you believe translate most effectively into the leadership? So, we have a number of practitioners that maybe listen to this and that they're interested in getting into that aspect of healthcare. What do you think translate, or what skills translate the best into a leadership role?
Yeah, I think that's a great question. And there are so many, which is why I feel really passionate about clinicians being in leadership roles and having seats at that table. But to be specific, first of all, I would say probably the educational and relationship and talking to people side of things. I'm a nurse first, and I think we are known for having good bedside manner, being able to explain things that may be complex and simplify them. And I find that that's a skill that translates to so many places, but has really been helpful in leadership. Um, so whether it's explaining something complex and breaking it down, or having a conversation that may be challenging with a high-powered superior. I'm thinking back to the days as an NP working overnights in the ER when I would have to call physician consults for my patients. The way things work, you're overnight in the ER, you might be one of a handful of providers, and when something complex comes through the door, you need the help of specialty physicians to make those clinical decisions. There were many a middle of the night when I would have to call and give a report to an attending physician who I knew I was waking up, and I had to be clear and concise and argue my case, get to the point, and not be nervous, even though there's always some nerves there, worrying that you'll be barked at. So I say those communication skills have been invaluable, and also time management and prioritization. So that's something I think that my clinical time has helped me with tremendously, prioritizing and triaging based on acuity or whatever it is you're triaging based out of or based on. That happens all of the time in a leadership setting or a non-clinical environment. So those are, I'd say, the two that definitely I cite every day.
Yeah, that's really good. And these are skills that do you feel like you developed those through your clinical training? I mean, what skills did you have to learn that you were never taught in clinical training that you're sort of figuring out that you need to have in a leadership role?
Yeah, I would say sales, and not in the traditional sense, in the sense that, I'm going to sell you the pen on my desk, but rather the art and skill of making a statement, explaining why it matters and getting buy-in from a group of people. That is so much of what we do is sales, in the very non-conventional sense. And I guess maybe there was indirectly some of that in the clinical training, but really um, there was no education in terms of the art of persuasion
Mhm.
or how to kind of argue your point or get buy-in. So I would say that's probably something I had to learn along the way.
Yeah, that's interesting. I mean, persuasion to me is really interesting because it really is an art, and I've seen it many times. I've been in leadership roles in the past. I've been an attorney for quite a long time, and some of the smartest lawyers that I've met, when they try to convey a point, it sort of falls flat, right? And it's only because that the messaging is off or the way it's conveyed is off. So that is it really is an art, and it's such an important way in how something in a very important message has to be communicated. It's a lot of times we, as humans, we pay so much attention on the way something's being delivered. Is it persuasive? Is it powerful? As opposed to the messaging that and it's just natural that's what makes persuasion so important. So that's really important. I had the first episode of this podcast. I had my brother on, who's a physician and he's an associate dean at a medical school now, and he talked a little bit about some of the training he didn't get when he was in medical school many years ago. And it was really in line with what you're saying, like, how do you communicate with people? And he makes it such an important part of their clinical training, the clinical education that, hey, it's great to be able to tell someone, and, "Here's the treatment plan. It's a great treatment plan. Here's the diagnosis. We got all this," but if you don't really effectively communicate it, then it's really gonna fall flat, and then, it's not great for the patient. But same with communicating with other providers. When you try to coordinate care with a patient, it's all about having that art of persuasion. In that case, like, how effectively are you communicating the message to other people? I think that's really important. What
Yeah,
what
I totally agree.
why do you think it's important for clinicians to have a seat at the leadership table? It could be in a medical group environment, it could be in a health system. Is it important? Why do you think if it is, why do you think it is?
I think it comes down to a few different things. I think representation is important when there's a group of leaders who are making decisions for or about another group of people. I think that that group of people should have a voice and should have input and representation. And I think it brings organizations a lot of credibility when they decide hey, we're going to bring someone who represents our clientele or whoever the body is that we serve, um, bringing them into big decisions, I think makes a big statement. I think that healthcare bedside healthcare workers who know the ins and outs of a day-to-day process can provide so much insight to a group that historically doesn't have a ton of insight into the day-to-day process. It's really part of why I continue to have a clinical practice is because I think it brings me additional credibility to the conversations that I'm having in my workplace internally and also with the different clients that the company I work for is serving. And I say I think that it helps with credibility, but to correct that, I know that it does. I've been told that it does, and there are so many examples of processes that were written without the the clinician in mind or the patient in mind in the right way that I've been able to correct and solve and improve as a result. So I just I think that it's also a really important way to showcase and honor the dedication and ability of bedside healthcare workers by including them at the table and in those decisions.
Yeah. So is it the kind of the boots on the ground type perspective? You have the most interaction with the patient. You understand what may or may not work from the patient's perspective because you're there. And my wife is a bedside nurse, and so and I have all the respect in the world for those that do bedside nursing, bedside medicine because it is challenging. But you really get a different insight on what the patient's needs are and probably develop some sort of empathy with respect to how certain things are received or not received and what's in the best interest of patients. So is that the perspective that's lost then when maybe a nurse practitioner or a clinician is not in that leadership role?
Yes, I think so. And I also think that healthcare workers and people in general are very creative. We are very creative minds, and giving that person who is seeing how decisions affect patients, how decisions affect leadership, kind of featuring that person who's consistently in the middle and elevating them. I think organizations will be surprised how much innovation and great ideas and efficiencies um, and just overall improvements can happen from that perspective. Yeah.
Yeah. No, that's really good. Um, all right. So, man, I would like to shift gears real quick. And you talked a little bit in your background about your work with compliance, emerging scaling healthcare models, and you work with organizations in wellness, mental health, functional medicine, aesthetics, as you mentioned. Where do providers, in your experience, most commonly create or see compliance risk?
It's a great question. I think when if we're talking about providers who are starting their own businesses or starting their own medical practices, I think that's to touch on our previous conversation, also a gap in education, right? There's not a lot of business training or training around the regulatory environment that happens during school. So a lot of folks who get to that point where they want to hang their own shingle, so to speak, are unless they have a great mentor or are otherwise involved in a professional organization, a lot of them are kind of cobbling things together on their own. And not everyone knows what they don't know. They don't necessarily know where to look for the different, regulations that they need to follow, or they may not even be aware of of certain things. For for example, someone an NP who wants to open their own practice may not be aware that there are local um, towns, counties, cities that have requirements on the zoning of a commercial building, or whether or not they need a sink in their exam room. Kind of these things just may not be necessarily on their radar. So I often encounter providers who are pretty familiar with their practice regulations in terms of do I need to have a collaborating physician or a medical director? But beyond that, aren't aware of, oh, can I legally own a practice that delivers medical care in my state, for example? Um, do I need to have a physician co-sign my chart or co-sign this prescription because it's a particular scheduled substance, right? So these are the gaps that I tend to see when non-physician providers are going into their own practices.
Yeah, the owning of the practice, that's a big one, and there are certainly more states that allow independent nurse practitioner ownership than there's ever been, than there used to be for sure. I mean, let's just take your example of a nurse practitioner setting up his or her own practice. Are there misconceptions of regulatory requirements, or is it, as you said, you just don't know what you don't know, or are there some the common assumptions that are made in this area, or is it just sort of just we don't know what the landscape looks like?
I think a lot of NPs, for example, might only know what they've seen their colleagues do, for example. So they might only have that as an example. I think the practice ownership piece is a great example of assumptions. Why would I even think that I couldn't file my own entity and deliver medical services, right? Like it's just not something I think that comes across anyone's radar unless they've had a personal connection or personal experience that has shown them that, because the amount of conversations that I have with folks about corporate practice of medicine who have never heard the phrase is very interesting. And frankly, before working in this environment, I had never heard the phrase. I was very unaware myself. So it does beg the question of how is someone supposed to learn about this information when it's not necessarily being disseminated in any sort of regular or structured way.
Right. Yeah, that's the corporate practice is one that I come across a lot. Just is sort of just unaware that these laws may or may exist. There are 33 states that actually have some sort of corporate practice of medicine law on the books, whether it's statute, regulation, or case law. And so when you talk to a nurse practitioner who lives in a state that doesn't allow it, and then you kind of talk about, well, there's some states are really pushing back on this, but there's the MSO PC model where okay, you
Mhm,
go get a physician that is a friendly shareholder of the professional entity. You own the MSO, and
mhm.
it's just so overwhelming that, there's so many, overlays and documents and everything that needs to be put in place to create that structure that it really causes some frustration sometimes. But yeah, it's not intuitive for sure, and, it can certainly cause frustration, but is important because the laws that are laws, and the consequences of violating those laws can be pretty significant depending on where you live.
Yeah, I agree. And I think an obvious first step is to have a consultation with a healthcare attorney before you're making these decisions, right? Like you and I would know that. Of
Good
course,
point.
that's logical first step. But, that NP may have an NP friend who has their own practice and they said, "Oh yeah, it's really easy. You just set it up yourself." There just can be a lot of hearsay that
Mm,
then turns into common practice. And I think that's kind of where the danger is because they're not necessarily consulting an expert, or they're consulting I online, which is generating incorrect responses, which I have seen more times than I'd like to count. So it's very interesting to see kind of where everyone is coming from as they come into this space.
yeah, and is that how organizations build compliance to their operations from the beginning? Is it a matter of just consulting with the right folks, or how do in your experience, have you seen organizations build compliance in the beginning rather than just treating it as an afterthought?
Yeah, I find that the groups that are most successful, most on top of things are having an attorney involved from the beginning in an advisory capacity, helping them with entity formation, and they're treating the business like an investment, and they're investing in the services and the talent needed to help get them set up right from the get-go. That's not to say that it can't be rectified with an afterthought, but in terms of a success indicator, I would say those who understand that, hey, this is an investment, not a hobby and not a side project. Those are who are taking the time to have the appropriate consultations and engage the appropriate service providers tend to be those who have most success, at least in my experience.
Yeah, it makes a lot of sense. We're talking about different business structures. You brought up investments, and there are a number of different models, right? In how you build a practice, you can go out and hang your own shingle, sort of finance it yourself. Another common way, especially now, is private equity. If you have established organization, you partner with a private equity partner that is getting some pushback depending on the state where you live. Uh, but it continues regardless to play a major role in healthcare. What opportunities, risks do you see with private equity investment in healthcare?
I think that there's definitely caution to be had when we view healthcare as a for-profit type of entity. So I think mostly to ethical implications of that. I think um I overall think that money is an excellent tool, right? No money, no mission is kind of a little adage that I have liked to use throughout my life. With funding, you can do great things. That said, there are a lot of ethical considerations, at least for me as a provider, where personally I've had to kind of check myself or check my thoughts on certain things when it comes to any sort of funding
Mhm,
in into healthcare and marketing and how patients and medical care is being viewed. So I think it's an interesting conflict in my opinion.
yeah, I agree, and I've always viewed it as it's trying to find the right balance. I agree with you. Private equity, to me, there's a lot of opportunities with private equity because with capital comes innovation, potentially, but, innovation which
Mm.
advances healthcare, is better for the patients, is better for our healthcare system. I'm with you, but it's striking that balance between that innovation and the professional judgment of again, again, the innovation in the best interest of the patient, but also the clinical side from a professional point of view, what is in the best interest of the patient. I mean, I think everyone, the idea is for if private equity is involved, the best interest of the patient should be involved. So you got the capital side, you got the innovation side, you've got the professional judgment side. As long as they don't conflict with each other and the sort of the capital is not overtaking the professional judgment side. I think everyone can agree on that, regardless of where you stand on private equity involvement. But I think there's certainly opportunities there, but it's sort of striking that balance. And so if a nurse practitioner came to you or an established medical group came to you and said, "Hey, there's this opportunity for outside investors," what advice would you give that person, or that group, before partnering with an investor?
Yeah, I think that those types of relationships need to be thoughtful and slow and have a good amount of diligence and lots of conversations between both sides because it ends up being a fairly long-term relationship and depending on what type of investment you're getting the who you're accountable to on the business side will change, right? If you're now accountable to a board of directors, then you need to make sure that you know your numbers inside and out and you can justify all the decisions that you make and be confident in the business decisions that you're making and to kind of go back to the earlier point of conflict. I think that's all the more reason that clinicians should have a seat at the table, right? To be another check and balance of of the ethics when we're talking about profit. But yes, to answer your question, I think diligence and treating it as a long-term relationship, dating before marriage is, I think, a good analogy of how you should treat evaluating any sort of capital investment relationship.
Yeah, that I love that. And you've seen, I'm sure, a number of successful partnerships, unsuccessful partnerships. What from your perspective is that distinction? Like what makes a successful partnership versus an unsuccessful partnership?
I think the people getting along makes a big difference. So the people who are on the investment side of things, knowing what their interests are, why are they particularly interested in your practice or your field, having honest conversations about what's the ultimate goal, right? Is the goal usually, at least for private equity, obviously the goal is for them to make a multiple on their investment. How are they going to support in that? Are they a strategic partner or not a strategic partner? Do they have relationships to bring in talent for your company that or your practice that will help achieve those goals? Just kind of making sure everyone's rowing in the same direction, I think are the important questions to ask and to make sure that your the business or the practice that you have, meaning you as the clinician or the owner, can it run without you? If it's super dependent on you being you being the value, then that will limit scalability. And if the business or the practice can't scale, then it can't deliver on what the investment company is going to want. So I think being really honest about those things, not just viewing it as a shiny financial opportunity, but understanding that there needs to be, a delivery or a deliverable, and being honest about whether the team has the ability to do that and can it scale.
Yeah, and speaking of scaling, so as you scale, how do you maintain clinical integrity as you scale, as you grow?
I think making sure that the scale includes bringing in additional clinicians, making sure that those clinicians are well vetted, and making sure that the scaling plan doesn't just plan on more more profit per patient, but more patients served, right? So thinking about kind of like horizontal versus vertical scaling. I think if you're scaling horizontally, which I view as serving more patients, then that's, both of those things can happen at the same time. But in terms of preserving clinical integrity, what new services are you offering? How are you improving that service? How are you expanding access? Leading with those questions, I think will help a clinician not be too tempted by, oh, well, double your price and serve a fraction of the clients and there's your answer because that's where integrity I think can suffer a bit. An interesting anecdote, my mom who's turning 70 this month, she's on Medicare, she's got a primary care provider who she just started with, a year or two ago, who she has a good relationship with. She was excited to find them, got a notice recently that they're moving to a concierge type model, which takes the insurance and also charges an additional like $5,000 per year subscription fee for additional testing and services. And we had an interesting conversation. My mom's a retired nurse of many years, and her perspective is, I'm retired on a fixed income. How dare they try to charge me more than what I'm already paying for my insurance premiums? And from her perspective, this practice has lost its integrity, right? Meanwhile, being in the industry I'm in, I'm like, oh well, this practice is probably seeing 25 to 30 primary care patients per day. The providers are burning out. They're barely scraping by based on the reimbursements. Right. I can see the path of what decided or what caused them to go in this direction. I think it's a really good example of, okay, was there an opportunity for them to preserve clinical integrity here without making it very obvious that the goal was to essentially cut their patient panel in a quarter and and double their profits? It's a really interesting real life example of this dilemma, I think.
Yeah, that's a great example, and you're seeing more of that sort of the injection of concierge type models or direct primary care models and these types of, uh, these payer contracts and, things like that because I think for a variety of reasons, but that's certainly a great example of why that could be the case, but, so man, I wanna be a little bit future looking here, and, you've had a lot of experience in this industry. How do you see the role of nurse practitioners evolving over the next 5, 10 years?
Oh, that's a great question. I would love to see nurse practitioners really holding their own as primary care providers in the landscape of primary care. I think that that's really where we shine and where we fill the biggest gap in at least traditional healthcare environments right now. We've heard all the different statistics about physician shortage or physician retirees or physicians who are electing to go into specialty more often than primary care. Meanwhile, more and more demand on primary care. I think that's really where we can fill the gap, but there's still some struggle professionally, I think, between nurse practitioners and physicians and the relationship between us. I view it very much as a partnership, and we're all part of the same team, a patient-centered team. So I would like for that kind of respect and um, positioning of nurse practitioners to stay and improve in the next 5 to 10 years. We're definitely a profession that's growing, um, so I'd like to see it continue to grow in a way that maintains our clinical training and our the rigor of our clinical training, because I think that that's something that could be in jeopardy um, if if not done appropriately.
Right. And do you think some of the things you described, like physician shortages, and certainly we know about all the projections related to that, and it's not great. But do you think that that will cause more growth in the independent practice of nurse practitioners and the flexibilities related to that over the next 5, 10 years? Or do you see that there may be some obstacles to that?
I hope so. I would love all those opportunities to be available for nurse practitioners to work independently if they wish, or work for health systems if they wish, or you know serve patients in a non-traditional healthcare environment if they wish. I think it's all of those pieces of kind of the healthcare web are necessary, and I think that nurse practitioners are well suited for all of those things that we described. I don't think nurse practitioners will or should replace physicians in any sense. I think that we have different training, we have different positioning in the care environment. So I think more of making sure that we're welcome in the spaces that we're in, and that we're trained well and have kind of the opportunity in the spaces that we want to be in would be would be my hope.
Yeah. Man, what gives you optimism about the future of healthcare?
Knowing that at least the clinicians that I've interacted with really all maintain integrity and ethics and recognize when things are good for patients and when things aren't. I think that there have been a lot of challenges to that in the past 5, 6 years or so. And I think as long as that continues to be the type of person who is delivering care and earning seats at the table of these bigger organizations and decisions that are being made, then that's how I can stay optimistic, I would say.
Yeah, I love that. There are so many negative things in the news about about healthcare and the system, but I love it. I love having discussion about what can we be optimistic about with respect to healthcare, and I think there's a lot. I think there are a lot of innovative models that are out there, and we're just trying to figure it out. So, and the fact that we have a growing practice of nurse practitioners, physician assistants, I think is a reason to be optimistic, and more opportunities for coordinated care. We've talked about concierge, primary care, direct primary care, all these different models on trying to figure out what is the best way uh, to coordinate care in a way that most effectively treats the patient. Right. So there's a lot. There's a lot. We should be optimistic. Let's be.
Yeah,
Let's,
we're gonna be okay.
yeah,
Because honestly, if you don't have folks that can stay optimistic, then where is the forward movement going to come from?
right.
Right? So that's I don't have any other choice is how I view that.
That's good. That's good. Well, Amanda, this has been awesome. This has been really informative. I really appreciate your great insights. I like to finish off every episode with a little lightning round, some quick questions. But my listeners are probably getting tired of this. Maybe not. But this is a sponsor segment. Lightning round today is brought to you by Western Associates. I'm actually wearing, you can see that if you're on YouTube, my Health Law Council branded shirt that was provided by Western Associates. They specialize in high quality branded merchandise, and it's stuff that people tend to keep and not throw away. This is good quality stuff. If you're thinking about organizing or upgrading your organization's brand through custom products, please check them out at westernassociates.com, or you can connect with Mike Eldridge at ELDRIDGE at westernassociates.com. We'll drop a link in the episode description as well if you'd like to find out more. So, all right, Amanda, I got a few lightning round questions for you. First, most underrated leadership skill.
Most underrated leadership skill, controlling facial expressions.
Hmm, that's a good one. That's a good one.
That's
Let me.
another one that I got from my clinical time,
Okay.
controlling facial expressions.
Yeah, I mean, when you're on a Zoom call like this, which I'm often on, and you can immediately see someone's reaction. It's good to have a poker face, I
Mhm,
think,
mhm.
when you're on a call with someone. Or in a meeting with someone. That's very good. Best lesson that you learned from bedside nursing.
Hmm. The the patient's history will almost always give you the answer.
Oh, that's great. That's great.
Mhm.
One thing healthcare executives should ask frontline clinicians more often.
What would make your job easier?
Oh, that's great. And finally, if you weren't a nurse practitioner, what would you be doing?
I'd probably be a romance book author.
Well, you
Maybe, I don't know.
can do that. Still, maybe
Never too late.
never too late. Never too late. Amanda, this has been great. I really appreciate the conversation. I love the insights, both on the clinical side, the business side of healthcare, growing practice models, private equity, and the kind of the pros and cons there, the way we can strike balance between innovation and respecting the professional judgment of the provider. I really appreciate your time. Thanks for your insight. Of
My pleasure. Thanks for giving me a seat at your table.
course. Thank you. Take care.
That's it for this episode of Health Law Pulse. I want to thank Amanda for her time and her really great insight. I really hope you enjoyed this episode as much as I did. A few takeaways really stood out to me. First, some of the most important innovations in healthcare are coming from clinicians who are willing to step into leadership and entrepreneurship. The individuals closest to patient care often have unique insights into how healthcare can be improved. Second, building a successful healthcare business requires much more than clinical expertise. Leadership, operations, culture, compliance, and financial discipline all play critical roles in creating organizations that can grow sustainably. And third, nurse practitioners are playing an increasingly important role in the future of healthcare, not just as providers, but as leaders, innovators, and business builders helping expand access to care and improve patient outcomes. For anyone considering practice ownership, healthcare entrepreneurship, or leadership, Amanda's journey is a powerful reminder that clinicians have a valuable voice far beyond the bedside. At the end of the day, healthcare works best when the people caring for patients also have a voice in shaping the systems that deliver the care. If you enjoyed today's episode, subscribe, leave a review, and share with a friend. We are on YouTube, Spotify, and Apple Podcasts. You can also find links to these episodes on my website at www.healthlawcouncil.com. We'll be back soon with more conversation at the intersection of healthcare, law, technology, and leadership. Thank you, and this is Health Law Pulse.